Hi, my name is Jennifer Fowler, and I will be talking about my systematic review of trauma-focused cognitive behavioral therapy. Um, and I wanted to say a little bit about myself. Before I started Kent School a few years ago, I had worked in child abuse prevention for many years, and we had done crisis counseling and family interventions in the home. And one of the first cases I ever had, it was this family, and there were about 3 or 4 children, very low income, living in poverty, and drug affected in this rural part of town. And when I was there, um, they were still suffering the consequences of drug problems, and one of the children had been placed in state's custody because the child had been sold into prostitution for drugs. Um, and this little girl was never in the home when I was there. She would come home to visit, but I was never there when she had her visitation. But she had huge issues of behavioral problems and developed some really dissociative symptoms and things like that. Um, and then I fast forward to Kent School, and then this semester, my first practicum is at a private mental health agency, and my first client is this little girl, the little girl that I'd never met. And she's there, had her own child removed, and still suffering from symptoms from past trauma, still disassociated, still antisocial, things like that. And I just thought from the very beginning that this family had all these services and all these different therapies, and whatever was used just didn't work. And then as I got more clients in there, I didn't have any of the other same clients, but you see so many people affected by childhood trauma that never dealt with it. So I thought it ended up being a really good topic for me. So the agency that I did get to was the Next Step Counseling Service, where I'm doing my practicum. It's a private agency doing mental health counseling. That's individual, group, family, couples. They do assessments, and then we have the school-based program. But many of these people work as advocates for mental health in the community. They work in child abuse prevention, sexual abuse, excuse me, poverty, and they even do like a homeless simulation around town. So um, they take private insurance, but they also take state-sponsored insurance and self-paid clients, and then people on sliding fee scales. They have a wonderful mission, and the goal is to make the counseling process a positive experience and support you every step of the way, hence the name Next Step Counseling. So everything's very strength-based and client-oriented there. So in came the Affordable Care Act about a year ago, and then the expansion of Medicaid. So now there's a surge of new clients with low-income characteristics. So the Next Step Counseling Agency, just at the beginning of the school year, formed a school-based counseling service for certain counties to alleviate any of these barriers for low-income family children receiving mental health. Um, so the school-based program does individual and conjoint family sessions at the school. Again, strength-based, goal-oriented. That you do assessments, and then we can do medication based on referrals to contracted psychiatrists and things like that. But this is all just mental health counseling within the school. There's 5 therapists. They range in education and experience, but they all have licensures. Each has different specialties like cognitive behavioral, rapid eye movement for trauma, which is very interesting, by the way. All of them do a little bit of different types of trauma narrative. Some of them do like expressive play therapy. Some of them have specializations in early childhood. But what I found through that needs assessment is most of the clients are Medicaid eligible. So that means 35% of the poverty level is what they're living on. And most all of them had trauma symptoms or past trauma. And then we also found that not one modality is used for treating children with trauma, because every therapist kind of deems what's appropriate as they meet each client. Um, but there's a correlation between low income and risk for certain types of trauma. And I want to be very cautious in saying that low income families are not at risk because of some inherent flaw, but usually because of all the stress or different ideology of the society, like single mothers or people with different ethnic diversities are more likely to be in poverty. So 16 million children in the United States are estimated to live in poverty. That's 22% of all children. And this can be traumatic within itself. They're at higher risk for homelessness, domestic violence, sexual assault, child abuse, and child neglect. And usually this has a lot to do with lack of mental health services or health insurance and stress related due to income, things like that. Trauma in children has also been correlated to psychological and physical problems, truancy, crime, and can cause impairments across all domains of functioning. Um, Trauma is very complex. It is expanded in the DSM-5 to a trauma and stressor related disorder, and it's got its own category now. That includes post-traumatic stress disorder, PTSD, adjustment, acute distress disorder like reactive attachment, disinhibited social engagement. And all of these cite prevalences in association with anxiety, mood disorders like depression, dysphoric, and disassociation. So there's different ways to scale and measure trauma, and that's what a lot of these articles, as we get a little bit further, talk about. So while the school-based program, because all these families living in poverty or with low income face a lot of challenges to affordable mental health, this population is also found to be resistant to therapy or counseling due to cultural perceptions. So a non-traditional treatment setting has been adopted as evidence-based practice for families and children living in poverty, hence the school-based. So we did the needs assessment. They talked about all these great things with the agency, but they really talked about all these children and everybody in the agency really that talked about trauma as one of the prevalent indicators of symptomology. All the people that I interviewed had a vested interest in the school-based program, so they talked about that a lot. They talked about wanting to have more things on trauma-informed care. And then again, not one type of modality was used. So my COPES question is, if school-age children in school-based therapy are exposed to trauma are given trauma-focused cognitive behavioral therapy versus treatment as usual, which will result in decreased trauma-related symptomology. So my organizing principles were, so the articles were put into 3 sections based on topic areas and relevance to my COPES question. And the first section is quantitative articles that incorporated a treatment as usual from strongest to weakest rigor. So there was 5 articles, 3 were very high rigor and 2 were moderate, but these were still, they were moderate to high, the last 2. A lot of similarities. 2 use treatment as usual that fit very closely to the next steps, so as far as individual treatment as usual deemed by the therapist. All of the articles showed decreased PTSD symptomology over treatment as usual with specialties in child-centered therapy, child behavioral intervention, trauma school-based, and non-directive therapy. But again, most PTSD scales have inherent properties of anxiety and depression, but almost all of these also scaled anxiety and depression with other scales besides just PTSD scales. But trauma focus was better in decreasing shame and disassociation over child-centered therapy and the cognitive behavioral therapy school-based, and better in anxiety and depression over non-directive. But that study was a little different than all the other more rigorous studies that were found in this one, and because it said it reduced anxiety and depression. And although the more rigorous ones found that trauma focus did decrease anxiety and depression, it wasn't any better than the treatment as usual. And then the cognitive behavioral child-based or school-based program showed better in reductions for depression, but that study was done after Hurricane Katrina, so it was hard to really talk about transferability to the next steps with that one. So the next topic was more quantitative articles that examined efficacy of trauma-focused cognitive behavioral components and as relevant to the agency's population. So all these showed improvements in clients for PTSD symptoms, similar to the other group. This group also gave me predictive findings in a possible school-based program to increase adaptive functioning and coping and decreased internalization and externalization behaviors. And these were across all different varying trauma experiences. So you'd have sexual abuse, child abuse, all those different things, traumatic grief. Um, so looking at all these, you saw that trauma-focused cognitive behavioral therapy was effective across cultures, across settings, across session durations that resembled the school calendar year that we would be using at the next steps, and varying experience levels of therapists, just like the next steps. The therapy also can show improvements without the use of the trauma narrative, because sometimes that can be deemed inappropriate in a school-based setting because they would have to go back to school after talking about it. Then there was one last one that was a qualitative article, and it was only one. It was from the client perspective being treated for trauma with trauma-focused CBT. And overall, all the reports from the individual children were great. This one, the kids were a little older in this, and the rigor wasn't that great because all the stuff was done over the telephone and things like that. So, but it did again give indication that trauma-focused therapy can be used and be effective over treatment as usual. Again, it's very complex, and we do need more research that implies effectiveness in the actual school settings because there was none of that. But I think that we can take some of these implications and put them over to that type of setting, since we know that the length of treatment and the way that things are done I know that they can be done in the school, and so does the next steps. So first, I would use this information to provide the agency with a presentation that described the effectiveness of trauma-focused CBT on school-age trauma victims across all different trauma experiences. And this would also highlight the existing school-based clientele population that we already have and the strengths of the program of overcoming barriers. So they would see that this would be needed. Then I would do a focus group of the school-based therapists at our agencies to discuss potential policy changes when dealing with trauma victims in the school. If needed, any process or implementation questions could be resolved in the agency group, or we could present those some of those issues to the family resource advocates that currently already work under a MOM with the agency and that do the school-based referrals. After a consensus was reached, I would do a presentation of the findings to the director, discuss the possible inclusion of trauma-focused CBT into policy and procedure for the school base for all trauma victims. And this presentation to the director would also include the nearest clinical trainings and possible manuals for the trauma-focused CBT. So with the approval from the director, then I would take this review and this presentation and go to the County Council on Child Abuse Prevention, which the agency is very involved with. And I would ask for inclusion for the trauma-focused CBT in the yearly regional trainings that they offer. They usually hire somebody to come in based on child abuse prevention funds and poverty funds. And then they also have these mini grants, and where usually after these trainings you can buy the materials through the mini grants. And I've wrote those before, so I would definitely want to do that for this. Lastly, a newsletter will be made that describes school-based programs and the efficacy of trauma-focused CBT to show the relationship between trauma victims, typical school-based client population characteristics, and low-income families at risk for trauma, to kind of tie it all together, to give the efficacy of the trauma-focused CBT and what the school-based settings really offer to families and to low-income populations. All right, thank you.